You can start now.
Thank you. Good evening, everyone. Welcome to the Facebook Live show. I'm Dr. Rajeshwari, Clinical Head and Fertility Specialist, Banashankari Third Stage, Bangalore. Today, we are going to speak or discuss the topic PCOS. First, coming to what is PCOS? Yeah. What is PCOS? PCOD. Patients do come and tell us, I've got PCOD, I've got PCOS. So we need to know what those terminologies are. PCO, polycystic ovaries. And when we see these polycystic ovaries, that is multiple cysts in the ovaries, on scan we call it as polycystic ovarian morphology. PCOD is polycystic ovarian disease and PCOS is polycystic ovarian syndrome. Both, and people do ask, what are these? Are they different? Are they same? Yes, they are both same. This polycystic, what we see on the scan, many these dark ones, black ones, they are the follicles, what we call it them as cyst. Naturally, one follicle comes for the race every month. One follicle develops or becomes dominant. For that, there are hundreds of follicles which get into the race. Here in this polycystic ovaries, due to hormonal changes, which I'll be discussing or talking about in few minutes, where there is, because of the hormone imbalance, they all get arrested at different stages of development and they remain as cyst. This is called as necklace of pearls. This is the way it looks like. That's why it is called as pearl or necklace of pearls and polycystic ovarian morphology of the ovary over scan. Polycystic ovarian disease was the terminology was used previously and now they use it as polycystic ovarian syndrome. Why do we say syndrome? Is there are many features seen in this polycystic ovarian women disease or syndrome women. 2 or 3 different combinations will be seen in one person. So we call that as a syndrome. It's a set of symptoms related to hormone imbalance. So this hormone imbalance, it gives rise to certain symptoms or features or what we call them as syndrome. This is one of the commonest problems seen in the women or the girls of reproductive age. It is also being seen in young adolescent girls and its numbers are increasing every day. And coming again to the definition, how do we define that? Defined and diagnosed by a combination of signs and symptoms by the Rotterdam criteria, that is androgen excess. Androgen is the testosterone or the male hormone, which is seen in excess in these women. That's why they do complain of oily skin, then a lot of hair over the body like men, or the face, upper lip, chin, sides of the cheek, then in the chest, abdomen, and on the limbs. This is how it looks. That's why we call them as hirsutism. And oily skin and acne will be there. That is a lot of pimples over the skin, on the face, back of the neck, all that may be there. That is due to this male hormone excess, androgen excess. Second thing is the ovarian dysfunction. Because of this excess male hormone, there will be increase of insulin levels as well. All this will give rise to dysfunction in the ovary. What I mean by saying is, in saying ovarian dysfunction is they may not ovulate, they may not get period because there is no ovulation, they may not get regular periods. So ovarian dysfunction happens. How does it happen? Later I will tell. Then polycystic ovarian morphology. That is what I already told. That is on the scan, what you see, polycystic. Many cysts are there. There'll be about 20, 25, more than 20, 25 follicles will be there, which will be ranging from 2 millimeters to 10 millimeters. And these features are given by the Rotterdam criteria, and at least two of them should be present to say that it is a polycystic syndrome. And before we say that it is only polycystic ovarian syndrome, there are other conditions which mimic or will have similarity with PCOS. That is hyperprolactinemia. Even they can have irregular periods. They may not ovulate. They may have difficulty in conceiving. These are the features which, and androgen excess can be there, and congenital adrenal hyperplasia, because adrenals also produces a lot of androgen hormone or the male hormone, and they may present to us with amenorrhea, that is no periods, regular, they will not have regular periods, the lot of hairs will be there, they can have obesity. So when we have a suspicion, before saying it is only because of a polycystic ovary or the polycystic ovarian syndrome, we have to rule out other conditions, these conditions, and Cushing syndrome. All these conditions, there can be excess male hormones, irregular periods, and hirsutism. So first, when we have to come to the diagnosis, rule out other conditions and to make sure that it is only because of polycystic ovary or the syndrome, all these features are seen. Again, coming to the incidence, it has got a wide range of incidence. In Indian population, it ranges from 8 to 22 or 26%, and nowadays there is a increase in this polycystic ovarian syndrome. That is because of our lifestyle. We have a sedentary lifestyle and the way we eat, all this is contributing to the increase in polycystic ovarian syndrome. 30% of all infertility is associated with anovulation, and 85, whoever is having anovulation, 85 to 90% of these are attributed due to PCOS. 21 to 59% of the women in reproductive age demonstrate ultrasound features, only ultrasound features of polycystic ovaries. Then what is the cause for this condition? There are many causes. It can be multifactorial, and we cannot exactly say this is the cause for the polycystic ovarian syndrome. Main thing is our lifestyle, what we eat, that is the nutrition, what we take, and the environmental factors. Environmental factors like all these plastics, the room spray, all these also do contribute, whatever sprays we use, do contribute for the development of or hormonal imbalance, which can give rise to polycystic ovarian syndrome. And it runs in the families as well. When one female in the family has polycystic ovarian, there is, in the first degree relatives, about 15 to 30% of them can have polycystic ovarian syndrome as well. Then how do they present? They may present, not all these have to be present in everyone. They may present with irregular periods or no periods. They can have very frequent periods, or they may have a delayed period, and some of them may not get period unless they take medication. And for some of them, if they start to have bleeding, they may not stop. So all this may be due to the male hormone which is produced in excess in these women. That may be due to the insulin resistance. They produce, say for example, a normal woman or a normal human being may require about 10 units of insulin to utilize 100 grams of blood glucose to take up that 100 grams of glucose. But in these women, they may have insulin resistance, means to say the body doesn't sense the insulin which is circulating. So they may have to produce, instead of 10 units to use that 100 grams of glucose, they may require 20 grams, some 50, some 100. So when they produce so much of insulin, it not only helps in uptake or utilization of this glucose, it goes and acts on the ovaries. When it acts on the ovaries, what does it do? It makes the ovaries to produce more of male hormone, that is the testosterone. This testosterone will have effect on the developing follicle, that is androgen environment will be there in the ovary, and these will act on, this hormone will have influence on the developing follicles. So they get arrested, they don't grow and come to dominance, they all get arrested and they remain in the ovary like a polycystic ovary. And because of that, they don't grow, and this hormone has influence, this testosterone or the androgen has effect on that, they get arrested. So there is no ovulation, they may not get regular periods, and they may have difficulty in conception also, because there's no ovulation. It's difficult for them to get pregnant. Then because of this androgen excess, this goes and acts on other part of the body as well. There is excessive hair growth on the face, as I already told, chin, upper lip, body, that is chest, back at the back of the body, and over the limbs. There is balding of the head, like men. You would have seen men do lose hair on the head, but they have strong or dark, thick hairs are the part of the body. The same thing may be noticed in these females as well. And because of this hyperinsulinemia or the insulin resistance, there is chance that they will put on weight. There is increase. It's very easy for them to put on weight, but very difficult to lose weight. And because there is no ovulation, they have difficulty in conceiving as well. And because of that appearance, a lot of hairs is there, a lot of pimples, acne, and obesity. That is, they have increased weight, and they have a low self-esteem. They may feel, how do I look? What do people think of me? And there is chance of all this depression, psychological problems as well in these young girls. And then pathophysiology, I've already explained. One is the increase in this hormone called LH. FSH and LH are important for the follicular recruitment, that is the follicles, the eggs to be come to the race, to develop and to ovulate. There is a ratio. FSH and LH should be of almost of the same proportion. But in these women, there is excessive production of LH, that is luteinizing hormonal. That also plays a role in causing or arrest of the development or not proper folliculogenesis or not proper development of the eggs. And ovarian synthesis, that is dysfunction of the ovary, as I've already explained, and insulin resistant and hyperinsulinemia. The pathophysiology, every step I have tried to explain. It's the same. More of insulin is produced, and this hyperinsulinemia goes and acts on the ovaries, makes it produce testosterone or the male hormone. That male hormone not only acts at the ovarian level, but it acts at the periphery as well. That is the hair follicular level, and causes obesity as well. And how do we diagnose this problem? One, by ultrasound. Two, by the few blood tests. What are those blood tests? We'll see. Ultrasound is the pelvic ultrasound, that is the vaginal ultrasound. When we do, we look at the ovaries, tubes, and uterus as well. These ovaries will be bulky. They will be having more than 20-25 follicles, which were ranging from 2 to 10 millimeters. And the volume, because they are bulky, the volume also will be increased. And which are the blood tests what we do to say, yes, this is a polycystic ovarian syndrome, that is FSH and LH levels we see. As I told you, they are approximately of the same value, but in these people, that ratio will be altered. That is 1:2. Means FSH will be half of the LH level and AMH level. Because so many follicles are there, their AMH will be very high. It shows that higher the value, it shows that there is resistance for the development of these follicles as well. Another thing is the testosterone. We want to differentiate between the ovarian cause of increase in testosterone from that of the adrenal cause, or many different other causes which can give rise to this amenorrhea, that is no periods, hirsutism, that is excessive growth over the body, and not getting pregnant. So we need to do testosterone level to know whether it is ovarian side or other side. Another thing is insulin resistance. When you do glucose tolerance test and insulin levels on fasting and 1 hour after the glucose, you will know what is the value, whether there is insulin resistance. And TSH, prolactin, we need to find out whether these are also contributing for the problem. Another thing is when these have people, polycystic ovarian syndrome people do have dyslipidemia, means to say there is excessive or altered lipid profile. That is the reason why we do the lipid profile and blood glucose level to see if as they have insulin resistance, they are at increased risk of developing this diabetes mellitus at a younger age. So we need to have a watch over the glucose level as well. And because of this increased obesity and altered hormone levels, they can have diabetes, then high blood pressure, the cardiovascular problems. These are all the other health problems which they can develop. Now coming to the treatment. Treatment will depend upon what the patient wants. What are her symptoms? Whether she is coming to us only for the regularization of the period, or coming for the excessive hair growth, or due to obesity, or she wants to conceive. So it depends on that. for whatever may be the reason why she's coming to us for treatment, the main and the foremost important thing is to advise on the lifestyle change. That is the very important thing, because that can alter many things and help her out in the additional medical treatment what we are going to give. What patient wants and what are her symptoms, as I told, whether it is periods, excessive hair growth, fertility problem. And if you're coming to fertility problem, you have to come for workup. We need to know what is her age and what is the duration of infertility she's having, and what are the previous treatments she has taken for fertility, and what is the scan finding, whether her tubes are patent, what is her male partner's reports, whether it's the men analysis, what I mean to say, whether what is the count like, morphology, and motility. All this will have, or to say, all this will influence on the treatment what we are giving for fertility. Then PCOS and fertility. First thing, whatever it is, lifestyle change needs to be done. That is exercise and the diet. They need to be on a low glycemic diet, one thing, and the regular exercise. They need high intensity exercise, 75 minutes at least twice a week, or 150 minutes moderate intensity exercise a week needs to be done. Foremost is, once the lifestyle is changed, eating habits, all the junk food or fried food, all these has to be reduced. Then coming to fertility problem means ovulation induction with medication or injections. Along with that, certain since they have insulin resistance, certain insulin sensitizing medication like metformin. Metformin is usually given for people who have diabetes, but here, because of the resistance, which insulin resistance, which it can help in sensitizing the receptors and help the body in uptake of the glucose, we do give metformin. One thing is that, and it also helps in better response of the ovary for the stimulation, and reduces the risk, moderate to a certain extent, not totally reduction of hyperstimulation. When we give all these medication for ovulation induction, especially the injections, gonadotropins, what we give, there is risk of hyperstimulation. That is, they produce more follicles, then fluid accumulation in the tummy. All this can happen. So it, to a certain extent, it helps in reducing to that hyperstimulation. That is OHSS, what we call. Another drawback of using this gonadotropins is, there is because they produce more follicles, there is increased chance of, when we are doing simpler treatment like ovulation induction and timed intercourse, or ovulation induction and intrauterine insemination, they have a chance, apart from hyperstimulation, they have a chance of high order multiple pregnancy like twins and triplets. Another thing is, for whom do we do laparoscopic ovarian drilling? The people who do not respond to the medication when we give oral medications like clomiphene citrate or letrose. These are the people whom you can give the option of laparoscopic ovarian drilling. But however, this is, however minimally invasive it is, it has got its own, it's a surgery, it has got its own benefits and side effects, like anesthesia will be used. It may be a daycare, but hospitalization will be required. There can be bleeding when you do the drilling, and it can cause adhesions. That is, it can draw the intestine towards one side to the pelvis, and the egg ovary can be drawn away from the tubes, because that tubo-ovarian anatomy may be altered. So that is one of the things. But advantages, you can check the tube simultaneously. Another thing is, when you do the drilling, it can, means to say, women can, to a certain extent, this hormone imbalance can come down. It will not come down totally to normal, but it can, to a certain extent, this impairment can get reduced, and they may start having more frequent periods. They may not get regular periods, more frequent. Ovulation may be there. They can try naturally. So these are certain advantage, and this especially for people who do not want to try have medication. You can do this ovarian drilling, or the people cannot come. They are staying in a remote village. They cannot regularly come for follow up. For these, laparoscopic ovarian drilling is helpful. If there is no pregnancy in gonadotropin using ovulation induction or gonadotropins, then then or pregnancy doesn't happen, then higher treatment is required. Higher treatment will be assisted reproduction. Assisted reproduction is the IVF or IVF. For whom do we do this IVF? For people who have lot of follicles, that is AMH is very high and they haven't responded properly for IVF, or they do not want to take the risk of taking hormones, too many hormones, or they do not want to have ovarian hyperstimulation. For them, we can give them IVM. This IVM is we give either we do not give, or that is one way of doing IVF. Another way is we give very minimal medication for the follicles to develop very little. We take out the immature eggs, grow them in the laboratory, that is in the embryology lab, and then fertilize them like any other IVF after that, and then grow them for 2 to 5 days, sorry, 3 to 5 days in the laboratory and transfer one or two or maximum 2 to 3 embryos into the uterus, and conception should be expected out of it. Then this is the overall treatment gross. And the women who do not want fertility treatment, who are only wanting regular periods, we can, and they have acne, that is pimples, and a lot of hair growth. For them, oral contraceptive pills should be ideal. And we should also advise them that at least they should get periods once in 3 to 4 months, or else it can have effect, or the endometrium can go in for hyperplasia. So we should advise every woman to have a period, mistake medication at least once in 3 to 4 months and have period. Now coming to what at the end of the talk, what is the message to be taken home? Take home message. One is early diagnosis. We see a lot of adolescent girls having PCOS, and it's very difficult for us to diagnose PCOS in adolescent because many of the symptoms are similar to that of the PCOS. So the way we have to, first 2 years, it is difficult to diagnose. They also will have excessive hair growth or oily skin, then pimples, irregular periods, and on scan they can have excessive follicles. That is like PCOS. May be difficult to diagnose that they are having PCOS. So they may be having irregular periods, then excessive hair growth, and irregular periods. For these people, we need to cautiously take the diagnosis of PCOS. And PCOS starts at a younger age. So lifestyle changes has to be implemented or emphasized in these people so that their future complications or manifestations of PCOS can be avoided, or to be to a certain extent reduced in the adolescence itself. So early diagnosis is very important so that fertility part also can be taken care of. Then lifestyle changes, as I already told, it has to be emphasized and emphasized and emphasized. That is diet, changing, having a healthy diet, then exercise, very important. Another thing is having, apart from treatment, having children, everything, after that, you need to have regular health checks. That is, you need to have your sugar test done at regular intervals, your lipid profile done so that you can have your blood pressure checked, so that you can early detection of any cardiovascular problems and lipid changes can be identified and treated. These people also, because of their obesity, they can have snoring and apnea, which may be very, what to say, because they may not be very alert during the time because they have a very disturbed sleep. All this helping them in reducing weight will help these people to overcome all this problem. So this is at the end, I would say lifestyle changes is the main important thing in handling PCOS. Thank you. If anybody has questions, please post it so that I can address it. No questions seen. One of my friend has PCOD since 14. She got married 5 years. 5 years. She have failed two IUIs and she went for IVF. But after injection given, doctor told that egg quality is bad. Is it the same for all? The quality may be compromised because of this androgen hormone, that is the testosterone, which is in excess. So for these kind of people, we first say what is her weight, you haven't told, and what is her age. Reducing the weight may help her in improving the quality of the egg. The PCO per se itself, because of this androgen excess, does have effect on the quality of the eggs. No chance of improving egg quality before IVF for PCOD people. As I told, reducing weight and using that metformin, that is insulin sensitizing drugs, these all may help in improving the quality of the egg. First thing is reducing the weight. When you reduce the weight, the male hormone, that is the testosterone level, comes down. The LH also reduces. FSH LH ratio will be altered, what I said. That LH ratio also comes down. That also will help in improving the quality of the egg. This hormone imbalance has to be rectified to whatever extent possible. That is by reducing weight. All this can have an effect. How can I increase my fertility with PCOS? So increasing fertility is reducing weight, and weight. Because if you are already lean and you're not able to have ovulation or regular periods, then having ovulation induction will help you. If you're on the heavier side, please do reduce your weight. There are many people who are overweight, not getting period, but they will be able, they would have conceived on their own, and they will not even know that they have conceived for 2 or 3 months, because they'll not be getting periods. Only after 2 months, or I don't get periods at all. After 3 months, I haven't got in my period. They will go and have a check. That's when they come to know that they are already pregnant 2 or 3 months. PCOS cannot be cured. PCOS will be there, but only thing is you can reduce your what to say, hormone imbalance. What is there? Only that 10 kilos you have reduced. Yes, I agree, but PCOD cannot be cured. Only the hormone imbalance, what is there, that can be reduced to a certain extent. Can single follicle cannot be produced in PCOS because I get more follicles during periods. Uh, Follicles do come, but all will not mature. Only one will mature during your normal periods. Only if you have induction of ovulation induction, you are taking treatment for fertility, only then when we give medicine, there can be more follicles developing. But otherwise, if you are naturally getting period or naturally ovulating, one or two will come to the dominance. All others will not come for the mature level. To get one dominant follicle also, hundreds of them will come for the race, but only one or maximum two in natural cycle, what I'm talking is, will come to dominance. That is mature eggs, what I mean to say. Infertile women have periods. Yes, definitely they have periods, and only few of them do not get periods unless they take medication. But otherwise, infertile women also get periods. But it may be irregular. How to detect endometriosis? Will it be detected in follicle scan? Because I am having heavy pain in period. Endometriosis, yes, by scan you can detect. That is endometrioma. If there is this endometrioma or endometriotic cyst in the ovary, then of course during follicular scan you can make out. And having heavy pain may not be only because of endometriosis. You need to get a scan done. They will tell you whether there is endometriosis. But if endometriosis is there, definitely it can be identified on scan. Only if there is ovarian cyst, that is endometriotic cyst is present, then we can detect on regular vaginal scan. What is difference between IUI and IVF? IUI is when we take the husband's sperm and we process it in the lab, and the best quality sperm are put into the uterus. That is, we bypass the cervix, vagina, cervix, and put it into the uterus, so that the sperm has to pass the uterine cavity, the remaining part of the uterine cavity, and the tube, and fertilize with the egg in the tube. IVF is when we make you produce, or when we make a woman produce many follicles, and we take out those eggs and mix the egg and the sperm and help, or make it to fertilize in the petri dish in the laboratory. So the embryos or the fertilization takes place outside the body. In IUI, fertilization takes place in the body. That is the main difference. Thank you.